Good afternoon, everyone. Thank you for joining us today. My name is Molly Alawade, and I'm the Director of Education here at the American Kidney Fund. Based on feedback we received from you, we are doing this webinar on sexual health and sexuality in kidney disease. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you should see on your screen. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of your control panel titled Questions. We'll see your questions and we'll do our best to answer them, either by replying to you in the questions box or out loud during the last several minutes of the presentation. This webinar is being recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. For those of you in attendance who are health professionals, we are glad that you joined us today and hope you'll recommend this webinar to the patients you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Without further ado, allow me to introduce today's speaker, Dr. Toby Gottheiner and Emily Watson. Dr. Gottheiner is currently the Medical Advisor of Medical Clinical Affairs at Satellite Healthcare. His role includes mentoring medical directors and providing project and initiative support to the MCA team. Previously, Dr. Gottheiner was in private practice for 25 years and served as a medical director at Satellite Healthcare until his retirement in 2017. Dr. Gottheiner attended medical school at the University of Cape Town in South Africa. His postgraduate training was at Stanford University Division of Nephrology, and he did additional training in the United Kingdom. Dr. Gottheiner is married with 3 children and 6 grandchildren and has been a resident of Palo Alto since 1978. He enjoys outdoor activities, travel, theater, jazz, and spending time with family. Emily Watson has been a social worker for over 16 years. She has worked in various settings, including outpatient family practice, infant adoption, and for the last 13 years, dialysis at Satellite Healthcare. Emily has worked with both in-center and home dialysis patients. Now, as the Director of Social Work for Satellite, her focus is to support the work of the social workers in meeting the needs of the patient population. On a personal note, Emily is married with 3 children, a new puppy, and lives in Santa Cruz Mountains of California. Thank you to Dr. Gottheiner and Emily for joining us.
Good morning. This is Dr. Toby Gottheiner. We're based in San Jose, California. It's a beautiful day outside, and we are both very happy to be with you and talk to you about this very important topic. For the record, we have no disclosures about any conflicts of interest.
Thank you. Good morning from California. Thank you, Molly, for that lovely introduction, and we're very happy to be here today. In addition to no disclosures, we also want to let you know that we are neither one of us trained sex therapists as we enter into this conversation. So I want to share with you what we're going to review today, the overview of our topic. We're going to talk about normal sexual function and then oppose that to what sexual dysfunction can look like. We're going to talk about the differences between males and females as they exist, and then focus on the increased risk for dysfunction in the specifically chronic kidney disease or CKD population. And finally, we do want to bring it back around and talk about treatment focus and options for treatment, specifically again for the chronic kidney disease patient population. Next slide. So when we look at a form, any form that we go to fill in, you might start with filling in the basics. You have your first name, your last name, your date of birth, and these are easy. And when it comes to this question, sex, does this mean male, female, or does it possibly make you feel like, yes, please, this is something I want, or possibly at some point in time, do you feel this way? So this is a question that is going to launch our conversation, and keep this in the back of our minds. We want to be lighthearted about this conversation, but there are some serious points we're going to talk about. So have you ever felt this way? Do you feel this way now? Does your partner feel this way? And is this why you've joined our conversation today? Next slide.
So let's first talk about normal sexual function. And the experts in the field, specifically Masters and Johnson and other people like Helen Kaplan, etc., have described this as 4 or 5 separate phases. First of all, you start off with the excitement phase, where you start off with under the right circumstances, a romantic event, certain circumstances, like the kids are out of the house. The excitement phase starts off with desire, where you have the sexual urge starting in response to a sexual stimulus. You then move on to the arousal stage, where certain changes take place in the body, such as a subjective feeling of sexual pleasure. The penis becomes engorged and starts to become erect. And in females, you start with constriction of blood vessels and vaginal lubrication, at the same time as which breast enlargement and the word tumescence occurs. This moves on to the plateau stage, where these sensations are intensified, and finally, during this phase, the orgasm stage, where you have ejaculation in the male and constriction of the muscles in the lower third of the vaginal wall in females. Now, it's important to know that these things don't always happen at the same time in males and females, and that's why understanding these differences may help partners better understand one another's bodies and responses and enhance the sexual experience. Then, after the orgasm phase, we get to the resolution phase, where arousal becomes diminished, and after varying periods of time, hours or days, the person is ready to experience this sexual function again. It's important to know that this is a normal body function and should be regarded as such. We know that most people think about sexual function on a daily basis, or so I'm told. And so that's the important thing about normal sexual function. Next slide, please.
Thank you, Dr. Geithner. As opposed to what normal sexual function is, we want to talk about what dysfunction can look like. So as we use this same cycle, you can see 3 X's on here, and we're going to talk about where things can stray from normal. There are 4 categories or classifications for dysfunction, and as you can see on this cycle, they can appear in the desire stage, the arousal stage, or the orgasm stage. What's not represented on here is the disorder or dysfunction in pain, and we're going to talk about that in a moment. These categories are the same for males and females. However, the actual issues will vary based on gender. Next slide. So when we talk about sexual dysfunction and these 4 areas of disorder, when we talk about a dysfunction, where that comes from is a statement or a marked distress by the person. This is what brings about or classifies dysfunction and disorder. So when we talk about a dysfunction or a disorder in desire, this is the lack of desire or lack of interest in sex. So for males and females, you'll see on this slide the different disorders or classifications according to the DSM-5. And you have a female sexual interest or arousal disorder, or a male hypoactive sexual desire. When it comes to arousal, This is the inability to become physically aroused. For females, we call this female sexual arousal disorder, and for men, more commonly, we call this erectile dysfunction, or you may see this shortened as ED. When we talk about orgasm or dysfunction disorder of orgasm, this is the delay or the absence of orgasm, and for females, this is the female orgasmic disorder or anorgasmia. For men, it can be a delayed ejaculation or actually can also include premature ejaculation. Finally, when we talk about disorders of pain, this is pain specifically during intercourse as the function of intercourse. For females, this is a little bit more common than it is for men. This can do a lot with physiological issues, genitopelvic pain, penetration disorder, or vaginismus. Some of this has to do with lubrication and changes in our physiology. And for men, we're talking about pain in the penis or pain in the scrotum, penidynia or scrotodynia.
So let's look at how does this look for men specifically. As Emily said, there are 4 classifications, similar for males and females. And in males, we see the problem with lack of desire, where there's no interest, the person is too tired, the person is not turned on. We'll talk about some of the risk factors in a little while. In terms of arousal or erectile dysfunction, we talk about difficulties in it, both initiating as well as maintaining erection, and oftentimes one or both can occur. Sometimes they don't all have to happen consistently. It can be something that comes and goes, and oftentimes emotional factors can be a factor as well. In terms of the orgasm, the orgasm can occur either too early or too late. Sometimes we see, as we said, delayed or premature ejaculation. There's also a condition called retrograde ejaculation, where the sperm and seminal fluid, instead of coming out of the end of the penis, gets projected backwards into the bladder, and this can also cause a significant distress. The commoner causes of this are when there's been surgery at the base of the bladder that affects the muscles that normally tighten up and prevent this happening. That is retrograde ejaculation. People have had major prostate cancer surgery, for example, is a risk for that. The problem of pain in the male organs is less common than for females, but certainly is a thing that can cause avoidance. Any cause of pain, one tends to deal with by avoiding the causes. So that is another condition that will cause problems with engaging in a satisfactory sexual experience. Next slide, please.
So let's talk about risk factors in females. And this is, again, talking about the general population and where and how sexual dysfunction can occur for women. Age and menopause definitely play a role in this as we think about those 4 areas for dysfunction in desire, arousal, orgasm, as well as pain. The changes in our chemistries, the changes in hormones related to age and menopause play a big role in those 4 possible areas of disorder. Lack of partner or a bitterness towards a partner could be part of this. If you are not interested in or feeling connected to a partner, this can definitely cause some dysfunction in your sexual functioning. Medications that we take for any number of medical conditions may have a side effect, especially for women, of causing vaginal dryness, which can lead to pain, which can then lead to a dysfunction. Childbirth or bladder and pelvic problems. These are structural, anatomical, or physiological changes that happen as a natural course in life that can have side effects that relate to sexual dysfunction or discomfort. Lastly, other medical conditions, conditions like diabetes, cardiac issues, high blood pressure. Many of these conditions in and of themselves can cause changes physiologically that lead to a decreased libido, as well as the medications or treatments for these can cause this as well. Anxiety and depression can stand on their own as forms or risk factors for sexual dysfunction. Feeling anxious about any part of our lives, but specifically about sex, feeling depressed about any part of our lives, or even specifically about sex, can surely cause a decrease in libido, desire, arousal, the ability to orgasm, and can even lead to causing pain. Finally, to be very clear, a history of sexual trauma is very significant and is strongly related to sexual dysfunction as well. Next slide.
So looking at risk factors in males, again in the general population, probably one of the most important causes would be aging. Now let me tell you that even in the general population in males, we see the onset of conditions such as erectile dysfunction occurring in as much as 40% of men over the age of 40. So just be aware, those of you with chronic kidney disease, you're not alone, and this is a very, very common problem. Medical conditions, commonest causes being hypertension, diabetes, and cardiovascular disease. It is known for a fact that men with erectile dysfunction have possibly, it could be a marker of cardiovascular disease because it is a blood supply issue. So that is something that I thought I should mention. Medications are another important cause, commonest ones being certain blood pressure medications and antidepressants. We'll talk about this in a while. Neurological conditions such as the neuropathy associated with diabetes is probably the commonest cause of erectile dysfunction, but other neurological conditions such as multiple sclerosis, spinal cord conditions, like that would be other factors. Obesity and cigarette smoking is a risk factor. And interestingly, I read that TV addiction is an important condition that can be associated with erectile dysfunction. Just think about it. It does make sense. Again, depression or anxiety, as mentioned by Emily, is an important factor. And, you know, relationship changes. We know that over the course of a decade, years, one's relationship with one's partner changes from a romantic phase to more of a companionship type phase, and this can be a normal thing that needs constant work. And it doesn't mean that every male who fits these above categories has diagnosed sexual dysfunction, and again, it may be transient. Next slide, please. So let's look at what happens in patients with chronic kidney disease. Why do things go wrong in chronic kidney disease? Well, in a nutshell, there's a lot going on. And if we start off with both males and females, primarily we'll look at hormonal changes that occur in chronic kidney disease. That starts off fairly early on in the course of progression of kidney disease and gets progressively worse as kidney function declines. A very brief background on the normal sexual hormonal organs. It actually starts off in the brain in an area behind the pituitary gland, so-called hypothalamus, and the pituitary, which secretes a number of hormones that travel to the sex organs, the testicles in males and the ovaries in females, where testosterone and estrogens are produced. Well, we know that the disruption in the hormone cycle does occur in chronic kidney disease, and the important ones to be aware of is a hormone called prolactin, which rises in concentration in the blood and is an important inhibitor of sex organ function. It is the hormone that causes lactation or milk production in females in the postpartum period, and this can affect the stimulatory hormones from the pituitary, which tell the ovaries and testes to make estrogen and testosterone. So these conditions can be measured and can be associated with conditions in females such as menstrual dysfunction. It's very, very common to see anovulatory cycles, that is cycles of menstruation where there's no ovulation, so fertility decreases, and milk production from the breast can occur. In males, the fertility decreases, and sperm count and sperm motility are impaired, and it really causes significant problems. In terms of other chemistries, we know that anemia, rises in blood urea nitrogen, and creatinine can disrupt the feeling of well-being. Vascular disease in males is enhanced in chronic kidney disease, so that the blood supply and the nerve supply can be an issue. Finally, depression, anxiety, and the effects of dialysis are significant factors causing fatigue. Next slide, please.
One of the discussions we want to have is about the similarities and differences about sexual dysfunction in chronic kidney disease patients. And this is really one of the steps where dysfunction can start. As you see across here, it's fairly common for males and females, up to 70% in males and up to 84% in females. It can go underreported, and it can affect your quality of life. And this boils down to possibly avoiding discussions with providers. And you can see these last three are very similar across both genders, between males and females. If there is no discussion with providers about these dysfunctions, there will be very little chance of making improvement. Sexual problems start with chronic kidney failure, and they're common and varied. It's found in at least 2/3 of hemodialysis and peritoneal dialysis patients, and numerous factors, both physical and psychological, may contribute. And it's probably less frequent in transplant patients, however, have been seen in certain studies to still affect up to at least half of transplant patients. Just as we know there are clinically relevant physical and physiological factors, I now would like to talk about psychological factors. Next slide, please. When we talk about the psychological effects, this is how we think and how we feel. And quality of life is really a goal for most people, right? It's living a long life, but usually living a long life is worthwhile if there is quality. However, what is quality? This is individualized, but this is what makes life enjoyable and worth living. Are you doing things that you desired or dreamed about in your life? Is that what you're getting out of your life? And are you doing what you enjoy? If not, are you finding alternatives, ways to get to bring enjoyment to this point of your life? Yes, chronic illnesses and chronic health conditions and their treatments may cause some changes in activities. So are there alternatives that you can still find pleasing that can lead to quality of life? If not, you may start to see the following: depression and anxiety, which can lead to a low libido or desire for sex. Is the depression and anxiety based in a clinical issue? Is it based in what you cannot or are not doing? Is it based in having a chronic kidney disease or possibly the treatment for chronic kidney disease? There certainly can be reasons to feel down and blue and depressed, or even possibly anxious or nervous, possibly about the course of treatment, possibly about starting something new, such as dialysis, possibly fear of a negative outcome, or possibly there could be a question or fear about sex. Is sex safe? And this is what we want to talk more about. Just as being unwell or being ill may bring about changes in your availability or your capabilities, doing things differently than before. Sometimes this can lead to working less or possibly working not at all, maybe even into retirement. And so as these changes come along, there could be a decrease in income. This could lead to higher financial stressors. And as we know, stress directly can affect those feel-good hormones and can inhibit that desire for sex. What about your body and body image, how you see yourself and how you believe you are seen by others? Being on dialysis specifically can mean an access to do your dialysis. Is that a PD catheter, a hemodialysis catheter, a fistula, or a graft? Any way you look at it, for patients on dialysis, there's going to be surgical evidence that you are on dialysis. Do you feel this is off-putting? Maybe you feel your partner sees this as off-putting. These are some of the factors about being on dialysis that talking about can help become more normal and less problematic. But those chemistries that we've talked about, maybe changing aspects of hair or skin or breasts, or maybe you're feeling less attractive due to some of the factors associated with chronic kidney disease or being on dialysis. There can be weight gain, weight loss. Another part of chronic kidney disease may be reaching out and asking for more support and needing more support by family and friends. For some, this could be uncomfortable. It could be a change in your position in your family or social setting, and feeling dependent or needing to ask for help can be a change. This can affect how we feel about ourselves, and it can affect or impact our desire to have sex or intercourse. Lastly, listing for or waiting for a transplant. For many, transplant is a goal. For some, it's not an option. All the same, this process of evaluating or being evaluated for a transplant and waiting for a response or waiting for a kidney can cause great anxiety. And again, as we know, anxiety and even depression can be stressful and cause an impact on those feel-good hormones, on that desire or libido. So all this is to say that patients adjusting to chronic kidney disease, the trajectory of that process, and or even to dialysis, it's not simply adding a treatment, but recognizing how these factors play a role in your quality of life. And many times, these other issues may feel much more pressing and important than talking about your low libido. However, we want to encourage you not to put off discussions about sexual dysfunction, low libido, low desire until too late. These are part of quality of life, and by bringing them up and discussing them, we're going to be able to address dysfunction and more important factors. Next slide.
So the question is facing you, what can I do? And in general terms, firstly, this is a body function or dysfunction that you should feel comfortable discussing with your physician. Now, sometimes, oftentimes, patients are embarrassed, they're uncomfortable talking to their physician about this. Maybe there's not such a great connection with the physician. A survey was done looking at surveying 160 nephrologists, and it was found that 10%, only 10% of nephrologists in the survey felt comfortable discussing issues such as fertility, menstrual problems, sexual dysfunction with their patients. So this is something that definitely needs better education in your healthcare providers. Also remember that you do have a primary care physician who may be more adept at discussing these issues with you. Secondly, review your medical condition. A complete history, a physical exam is important. and sharing concerns with those of your partner is also very important. Thirdly, an important cause of sexual dysfunction includes medication. So review your medications. Perhaps one of your blood pressure pills can be switched to an alternative that doesn't have this effect. Some of the antidepressants, if they're being used, can be switched around to some other alternative, but importantly, do not stop or change any medications without your doctor's input. We do not want to see rebound spikes in high blood pressure, conditions like that. We also know that patients starting off on dialysis don't feel well and can take weeks or longer for new dialysis patients to start feeling better. So optimize dialysis. Make sure that you're getting adequate dialysis. Don't cut your treatments short. And then consider counseling, as I discussed previously. Social workers are trained to discuss this to a certain level, and so you should be discussing this as well in your quality surveys with your social worker as well as your doctor. And moving on to more specific forms of treatment for males and females. Next slide, please. First of all, let's talk about males. We look at the changes that take place, both hormonal, chemical, and medication. First of all, we know that treating anemia can be helpful, both in terms of energy level, feeling of well-being. So, the treatment of anemia and chronic kidney disease can involve use of iron, as well as the stimulation agents such as epogen and Aranesp. People have tried suppressing prolactin. For example, there are drugs such as bromocriptine that suppresses prolactin, and this drug is used in other conditions such as pituitary tumors where excessive prolactin is being secreted, and that will suppress prolactin levels. But drugs like bromocriptine and cabergoline have not been all that effective. It's usually given twice a week, and it shouldn't be used if there's severe high blood pressure, and it can have side effects. So not great results with prolactin suppression. Probably the most effective and important group of drugs that most of us know about, the so-called blue pills. I'm going to spend a little bit of time talking about these. The classification of these drugs are called the phosphodiesterase 5 inhibitors, and the one that is probably best known to all of us is Viagra or sildenafil. Comes in 25 to 50 milligram tablets. Its length of action is about 4 hours, but it can have side effects. It can cause some visual changes. It can cause flushing. It can importantly cause transient drops in blood pressure. In fact, this drug was first developed as a blood pressure lowering drug, but this additional side effect which was found made it into the blockbuster that it is. Another very rare side effect is priapism, or a permanent erection, which becomes a medical and surgical emergency. There are other phosphodiesterase 5 inhibitors. You've probably all heard of drugs like Levitra and Cialis, which are somewhat longer acting. Cialis comes in a daily dose, as well as a so-called weekender, which is a longer acting drug. And there's also a sublingual tablet called Staxin, which is put under the tongue, which is another form of Cialis and acts much quicker. Studies looking at this drug in chronic kidney disease patients shows that can be an 85% improvement in erectile function as well as satisfaction. The important thing, as I mentioned before, is that it can cause drops in blood pressure. So patients who are taking drugs like nitroglycerin should be cautioned against the use, and probably not a great idea to use it prior or soon after going on dialysis because of its effect on blood pressure. Another drug which has been found to be helpful in both males and females are zinc supplements, probably a lesser effect than the previous drug that I mentioned. And in a small study, it has been shown to improve sexual function, possibly by increasing testosterone level. People have tried the pill form as well as putting it into the dialysis solution. The latter form is not found to be helpful. So this is another thing that you could look at. Testosterone supplements have been used, probably not all that effective, and have to, even though the testosterone levels tend to be low, but a little effect on improving sexual function. Treatment of depression and anxiety can be important, but remember, as I mentioned before, antidepressants can have a side effect of delaying ejaculation and causing sexual dysfunction, erectile dysfunction in their own rights. Optimizing dialysis can be helpful and certainly improving the chemistries. Now, interestingly, there was one study that showed that actually getting yourself on the transplant list can have an enhancing effect on your mood, I guess feeling of hopefulness, can improve sexual function. Next slide, please. And finally, the mechanical devices, there are vacuum devices that can be applied to the penis, which causes blood flow, causing erection. Penile injections, although very scary sounding, can be effective, and this is using a prostaglandin-like substance to inject into the penis, which causes the blood vessels to open up and allow blood flow. There is a substance called the Muse system, which is a little tablet that gets inserted into the tip of the penis, which can be effective. And then finally, penile implants, which is a surgical procedure done by urologists, which result in a device inserted into the shaft of the penis, which can cause can cause a permanent erection, but there is a bulb system which you can use to cause the erection as needed. Next slide, please. Females, well, this is less well studied in females, unfortunately, and in general terms, we spoke about anemia treatment, zinc supplements. People have thought about the use of Viagra, but there are no really good studies in patients with chronic kidney disease. Some people feel the use of progestins to initiate menstruation can be effective. A very important topic would be the use of lubricants. Vaginal dryness would be more common, especially chronic kidney disease patients who tend to be older. Treatment of depression, anxiety can be a factor. Optimizing dialysis, listing for transplant. And just remember that pregnancy is something that does occur in chronic kidney disease. Fertility diminishes as the disease progresses, but we have patients who get pregnant even on dialysis. And I'd like to just talk a little bit about some reproductive issues. Next slide, please. So reproductive health changes in pregnancy ability is a complex decision. Contraceptive choices may be limited. Estrogens can be these are the commonest oral contraceptives. Side effects of blood clots, hypertension, cardiovascular disease. Progestins are not all that effective. Possibly the best would be the barrier contraceptives, such as condoms, with the use of a spermicide. There are some issues about the intrauterine device, which can cause some risk in peritoneal dialysis patients and patients on immunosuppression. Kidney disease treatment can affect fertility. A drug like cyclophosphamide, which is used in patients with lupus, and pregnancy itself is a completely topic of discussion on its own, and I'm not going to spend too much time on this except to mention that can be extremely complicated with risks to both mother and female, and timing should be a joint decision-making between the patient, the partner, and the physician. In terms of transplantation, probably pregnancy is best waited to occur a year after transplantation, possibly even longer. Next slide, please.
So I'd like to talk about the role of therapy. As we've talked about how medical issues can be addressed, and there are many medical interventions, oftentimes people look to therapy as well to address some of this sexual dysfunction. Sometimes the sexual issue or dysfunction is based in an emotional issue, and talking through these can help resolve the dysfunction. What we think affects how we feel, and what we feel affects what we do. This is the basis of human behavior, and one of the ways we can begin to look at addressing issues such as depression and anxiety. Talk therapy can support any of the aforementioned treatment options that Dr. Gottheiner mentioned. If on dialysis, you have a social worker at your center who is available as a resource and as support. A therapist independent of dialysis and your other care providers can help identify and address these thoughts and thought patterns that can affect how you feel. And then talking about sexual dysfunction or the effects of your treatment or dialysis absolutely can help identify solutions. Finally, make a quick caveat that sex therapy is an option for folks interested in this. It is a specialty therapy that may help when talking about sexual dysfunction. Next slide. So key takeaways that we want you to think about leaving this webinar is talk with your physician, your primary care doctor, your nephrologist, your urologist, your OBGYN. Talk with your social worker, especially if you're on dialysis. Sexuality and intimacy are much more than sexual intercourse alone. So think of this as that human relationship, a feeling of closeness. Just touching, holding hands, hugging, kissing, cuddling can increase those feel-good hormones, which can start that cycle that Dr. Gottheiner referred to in the very beginning of this presentation. Please be reassured that sexuality, feeling sexy, being interested in sex is very safe. Talk with your doctors about problems that may be a part of this. And then recognize, lastly, that relaxation, an exercise program, a feeling of well-being can help bring about a decrease in any sexual dysfunction you may be considering or witnessing or sensing.
So finally, I'd like to thank everybody for joining us for this talk about this very important topic. It's clear that we all have more work to do on the subject to bring it to people's attention and to improve this very important part of your lives. Thank you.
Well, thank you so much. We want to say a huge thank you to Dr. Gottheiner and Emily for joining us and for leading such an excellent webinar. So at this time, I'd like to ask the two of you to answer a few questions we've received over the course of the webinar. So the first question is there a remedy for retrograde ejaculation?
It depends on the cause. Generally speaking, if it is based on surgical removal of the constricting muscle at the base of the penis, probably not. I think it's important to understand that retrograde ejaculation doesn't take away from the sensation of orgasm, so that one can certainly have the pleasurable experience of orgasm, but without actually having the flow of semen out the penis. Now, this does become a condition during, in terms of fertility, so that if the attempt is to get one's partner pregnant, then there are certain ways in which sperm can be extracted from the testicle and the tubes to achieve this goal. I hope that answers the question.
Thank you for that great explanation. Our next question comes from a dialysis patient. This patient reports being impotent for the last 20 years due to diabetes and neuropathy. So have there been any recent advancements for this situation?
I think I tried to cover this topic in the talk, going through the various treatment options, both the drug treatments and then the mechanical treatments in terms of vacuum devices, injections, the Muse system, and the ultimate, of course, is the penile implant, which I think has had great advances made in terms of the technology and the flexibility of using the device to achieve an erection when it's needed. Now, this is obviously something that's handled by specialists in the field, usually a urologist. I've had patients who've had penile implants that have been quite effective, but one has to consider the appropriateness in terms of causing blood flow problems and surgical candidacy.
Okay, great. So our next question is about transplant. You mentioned that half of transplant patients still report a lack of sexual desire. Is this due to immunosuppressants?
I think there could be two factors to this. Definitely many medications have a side effect that may decrease libido and affect our hormonal levels. However, there can also be the other possibly less focused areas of anxiety and depression that may be related to our medical history. Even though transplant is now in place, there could still be some considerations or fears or thoughts connected to that may affect whether it's an arousal disorder or a desire libido disorder. So it's definitely something to have a discussion with your physician about, evaluate all of those medications to start.
All right, well, thank you for that answer. So our next question is there any new research finding on Viagra and the impact on dialysis patients?
Not that I know of that's anything new other than I've mentioned. I think it is probably the Viagra and the similar drugs have the probably greatest effect in males. We don't know too much about the effect in females. There have been some studies, some thoughts to suggest that females may also benefit from Viagra, but the data just isn't there. I think that it's certainly one of the first-line therapies for erectile dysfunction and should be considered in every patient except where there are contraindications. Again, the most important contraindication would be patients who are taking short or long-acting nitrates for angina and other blood pressure lowering drugs, which it can enhance the effect. Certainly dialysis lowers blood pressure, so that would be the biggest concern.
All right, thank you for that response. So before I jump into the next question, I do want to remind our listeners that if you do submit a question, it is totally anonymous. Only the AKF team can see that you submitted a question. None of the other participants will be able to see that. So please feel free to ask any questions you may have. So going off of that, actually, our next question is, as a professional, how do you address patients who are hesitant or embarrassed to talk about sexual health?
That's an excellent question, and I think that for professionals, having worked in the dialysis field for many years, I know that we are trained, nephrologists are trained to take care of kidneys and kidney care. Nephrologists, nephrology social workers are trained to focus on the patient and adjustment, and a big part of both of our roles is quality of life, and a big part of quality of life is sexual function. I think the comfort level for professionals is what we need to, as a field of expertise, we need to become stronger in, being comfortable having discussions like this, understanding how important sex and sexual health is to every individual. And when there is a problem here, we need to make that space an open, caring, comforting, and safe space to discuss. So the more comfort physicians, social workers especially have with this topic, the better care we can help provide our patients.
I think just as an additional point, sometimes, and this is understandable, and it is a fact that patients will feel more comfortable talking about this with a same-sex physician, same-sex social worker. So, but whatever makes one feel more comfortable talking about it, just bring the topic up, and you know, oftentimes the doctor or the social worker, more commonly the doctor, needs to be sort of encouraged to talk about it. Don't assume that they will jump into this discussion without a sort of little opening of the door. So feel empowered to talk about it. It is a completely normal body function, no different from any other body function.
Well, that's very well put. So building off of that, our next question is, I've noticed nephrologists defer to a patient's primary care doctor. How can we get nephrologists on board to talk about sex?
That is an excellent question, and the answer is we need to do a lot more work in educating nephrologists. I don't recall having the subject taught to me during my nephrology training. It certainly is in the literature that one can read about, but I think it's a thing that one must start to feel comfortable talking about oneself. It is certainly something that is lacking in the nephrologist's care. You know, oftentimes they're rushed and they want to get on to the next dialysis patient, so or the next patient with chronic kidney disease, and you know, we're all human, and it can be something that people just don't feel comfortable talking about. So the answer is we need to do more work.
Well, that's great. So the next question is, how does menopause affect libido for someone who also has CKD?
I think that libido, if you think about, you know, what is the purpose of sexual activity, and, you know, I guess on a very primitive level, it is the process of procreating to have kids, and I guess that maybe we are programmed, I mean, this is just my own thinking, programmed to become less sexually active, although this certainly doesn't apply to everybody. People in the 60s, 70s, and 80s still enjoy sex. But I think that it certainly would be consistent with the normal changes that take place with aging, where there's loss of libido, vaginal dryness, erectile dysfunction that takes place as you age. I think all of these effects are magnified in chronic kidney disease, so that where maybe 40–50% will be affected at a certain age, certainly more with people with chronic kidney disease will have the same problem.
Okay, thank you for that explanation. So our next question is, do you have any recommendations for addressing this topic for adolescents or teens with CKD?
With CKD or PKD? I didn't get the last thing.
CKD, chronic kidney disease.
I would say most of the focus of our topic and our research was on the adult population. I believe sexuality in youth is in and of itself its own topic and area of expertise, as developmentally bodies are changing, emotions are changing, hormones are raging, if you will. And I think sexuality in youth is very, very unique and not something that we necessarily focused on in our presentation today. When you then couple that with the changes that happen with CKD, as Dr. Gottheiner has referred to, the changes in our chemistries, focusing on medication and treatments to stave off, say, dialysis, absolutely may have an impact on sexual function and, of course, on body image. And I think that these will be compounded to an already difficult time in sexual development in youth. But I cannot say specifically without much research.
Yeah, we generally have a separate division of nephrologists who take care of young people, the pediatric nephrologists who may certainly be better attuned to discussing this topic, because I'm sure it comes up with them as well. So that's the best advice I can give you right now. But certainly the hormonal changes will be similar in the youth in terms of the pituitary and the gonadal changes that take place.
All right, well, thank you for that advice. So our next question is, how soon after transplant can you resume having sex?
Well, I was going to crack a joke and say, I guess when the anesthetic is worn off, but no, I think it's safe to assume sex when your body tells you it's okay. I mean, certainly the wound is down in the right or left lower quadrants of the abdomen, so one wants to have that wound completely healed. Sutures must be out. The tenderness related to the surgery must be resolved, and I think this transplant surgeon with the follow-up post-op checks will give you the go-ahead, and I don't see any reason why one just can't listen to your body and get the advice of the surgeon, which will tell you go ahead and resume normal activities, and normal activities include sexual activity.
All righty. Our next question is, can you go over catheter safety and sexual relationships?
Are you referring to peritoneal dialysis catheters? I assume you are, Molly?
Yes.
Okay. Well, first of all, the properly placed catheter is usually exiting on the side wall of the abdomen. So it's usually not exiting in the central part of the abdomen. So it's the exit site is a downward facing, laterally placed, sideways placed catheter. So I think the answer is it's quite safe. I guess you want to make sure the catheter is secured against the skin so it doesn't get trapped in, body contact movement and things like that. Basically, simply put, get it out of the way. And I think that whatever sexual position works for the couple is the right one. I think that there should not be any increased risk of exit site infection or God knows peritonitis. So I don't think there's anything extraordinary about the position, the fact that there's a catheter, except in terms of body image and things like that. Quite safe.
All right. Well, we have one last question, and then we'll wrap up. Are there any statistics comparing sexual function for different types of kidney disease? For example, PKD, polycystic kidney disease, versus CKD, chronic kidney disease?
Well, certainly PKD is an important, it's a good question because polycystic kidney disease can and does result in massive organ enlargement, both liver and kidneys, which can fill up the entire abdominal cavity and even go down into the pelvis and cause constant pain or discomfort or distension or feeling of fullness or dragging, back pain. So that in its own right can be an impediment to satisfactory sexual function. So that is an important thing to be aware about. Sometimes when the patient is already on dialysis or even transplanted, these organs can be removed, not the liver, the kidneys. Sometimes a very dominant cyst, a single cyst or two cysts that's causing symptoms can be decompressed by a relatively simple procedure, a cyst drainage procedure, which can be done by a competent radiologist. Certainly, diabetic kidney disease is a whole separate topic, and in terms of its effect on causing neuropathy and erectile dysfunction is an issue. Cardiovascular issues are an important cause of erectile dysfunction. What else can I think of? Patients with lupus sometimes have to get treated with a drug called cyclophosphamide, which can cause fertility issues, raising questions of egg preservation, things like that. But yeah, I think the important thing about polycystic disease is what I mentioned.
All right, well, wonderful. Thank you so much for your explanations. So thank you again to Dr. Gottheiner and Emily, and this concludes today's webinar. Our next webinar will be about managing side effects of late-stage kidney disease. This webinar will be held on Tuesday, August 20th, and hosted by Dr. Gopa Green and social worker Diane Ruddle. Registration is now open. Visit kidneyfund.org/webinars for more information and to register. When the webinar closes, please do not close your browser window. You may see a pop-up saying that the webinar has ended. Please close that pop-up and proceed to the webinar evaluation survey. Your honest feedback will help us to make our webinar program the best it can be. Thank you for joining, and we hope to see you again.